Check the hands for clubbing, tobacco staining, coal dust tattoos, or other conditions that affect the hands and may be associated with lung disease, such as rheumatoid arthritis, which may cause nodules, or systemic sclerosis. Feel the pulse, and if it is bounding or if the patient is cyanosed, check for a flat ping tremor of the hands, which is due to CO2 retention, or a fine tremor due to beta agonist therapy. If there is doubt about the presence of cyanosis, you should at this point check the tongue and the buccal mucous membranes over the premolar teeth. For moving on to the neck, to look for raised venous pressure, which may be due to cor pulmonale, or fixed distension of the neck veins, which may be due to superior vena cava obstruction. Next, examine the trachea. Place the index and the ring fingers on the manubrium sternae over the prominent points on either side. Use the middle finger as the exploring finger to gently feel the tracheal rings to detect either deviation or a tracheal tug. The middle finger may be pushed upwards against the trachea by the upward movement of the chest wall. Check the notch cricoid distance. Feel for lymphadenopathy, which may be due to carcinoma, TB, lymphoma, sarcoidosis in the cervical region axilla. As the right hand returns from the left axillae, look for the apex beat. Difficult to localize if the chest is hyperinflated, which in conjunction with tracheal deviation may give you evidence of mediastinal displacement, for example due to collapse, fibrosis, pneumonectomy, effusion, or scoliosis. Look for asymmetry. Rest one hand lightly on either side of the front of the chest to see if there's any diminution of movement. Next, grip the chest symmetrically with the fingertips in the rib spaces on either side and approximate the thumbs to meet in the middle in a straight horizontal line in order to access expansion first in the inframammary and then in the supramammary regions. Note the distance between the thumb and the midline, which may give further information about asymmetry of movement and between both thumbs, and try to express the expansion in centimeters. It is better to produce a tape measure for more accurate assessment of the expansion in centimeters, comparing both sides at each level. Percuss the chest from above downwards, starting with the supraclavicular fossae and over the clavicles, and do not forget to percuss over the axillae. Few clinicians now regularly map out the area of cardiac dullness. In healthy people, there is dullness behind the lower left quadrant of the sternum, which is lost together with normal liver dullness in hyperinflation. Tactile vocal fremitus with the ulnar aspect of the hand applied to the chest. Auscultation of breath sound should start high at the apices, and you should remember to listen to the axillae. You are advised to cover both lung fields first with a bell before using the diaphragm, if for no other reason than this allows you a chance to check the findings without appearing to backtrack. In the nervousness of the examination, harsh breathing heard with the diaphragm near a major bronchus, for example over the second intercostal space anteriorly, or below the scapula near the midline posteriorly, may give an impression of bronchial breathing, particularly in thin people. Compare corresponding points on the opposite sides of the chest. Ensure that the patient breathes with the mouth open regularly and deeply, but not noisily. Auscultation is complete by checking vocal resonance in all areas. If you have found an area of bronchial breathing, the sounds may resound close to your ears, agophony. Check also for whispering pectoral loqui. The classic timings of crackles, crepitations, various origins are early inspiratory, which is chronic bronchitis, asthma, early and mid-inspiratory and recurring in expiration bronchiectasis, which is altered by coughing, mid-late inspiratory, restrictive lung disease, for example fibrosing alveolus, pulmonary edema. To examine the back, sit the patient forward and repeat all the steps. You may want to start the examination of the back by palpating for cervical lymph nodes from behind, particularly the scalene nodes between the two heads of the sternocleidomastoid.